All right, everybody. We're on the home stretch. As you can see in a minute or two or less, the energy level is going to go up tremendously. We're going to high test now. We're going to high octane gas. And we have an opportunity to hear from Peter Merkel, who's going to talk to you about ANCA-Associated vasculitis, diagnostic and therapeutic challenges. Peter.
Thank you. A few quick remarks. First of all, I just want to thank Michael. It's been wonderful to plan this program, the two of us together. And that's the fun, and we get a little bit of the glory. It's been great, and our speakers have been wonderful. But actually, the crew at Cedars-Sinai have been fantastic in putting together the CME program, getting the word out, and all the material, as well as working with the Vasculitis Foundation, which, as you've heard, is the largest group for advocacy for patients with vasculitis, and that's the patient group committee next door. So that's been a great deal of fun to work with Cedars on this. You all have some pads in front of you. There's some blank pages. We're going to ask that, for the most part, the questions be written out. Write out the questions you're going to want for the panel. We then will sort some of them out and answer. There'll be some, because we don't have microphones, and it's a more efficient way to do things, of course. And as usual in this kind of thing, we'd prefer not to have the my case, my patient kind of question, because that really doesn't work in this forum, but rather a more focused question. So, I'd like to duly noted that I'm starting 3 minutes late, Dr. Weissman. So, because I have only 106 slides, so we'll be fine. ANCA-Associated vasculitis, a passion of mine along with all the other vasculitides. There's a lot to be said. This is an exciting year for some new data, which I will tell you. I do want to tell you that I have some financial disclosures. As we all do, I do drug development in vasculitis and scleroderma, and over the last several years have received and worked with companies. I will be talking about off-label use. I will only be talking about off-label use because this is rheumatology, and more importantly, this is vasculitis. And our goal is to get some of these things labeled so that we can work together to get the patients the agents we need. And I think we're getting to that point. A lot of the work that I will allude to from our own research, most of it is funded by the NIH or the FDA, and so we appreciate it if you continue to pay your taxes. Today I'm going to do an overview of small vessel vasculitis and its classification issues briefly. Classification vasculitis continues to be an area of interest. We're actually going, part of a group that's leading an effort to rethink about the classification. No system is perfect. We still tend to talk about the predominantly small, predominantly medium, and the predominantly large vessel. And then there's the group of stuff that doesn't really fit in any of those rubrics. And today we'll be talking about, for the next two talks, we've already heard about large vessel disease. We're going to concentrate on the so-called ANCA-Associated vasculitis, a term that is not ideal. Microscopic polyangiitis and Wegener's will be my topic, and then Ulrich Specks will talk about Churg Strauss. What's in the name? Well, as you know, we like to be as confusing as possible in medicine. Multiple names for different things with overlapping features. Wegener's granulomatosis, microscopic polyangiitis, they are considered separate diseases with a huge amount of overlap clinically and therapeutically. People refer to ANCA-positive vasculitis, but that doesn't encompass everything because there are certainly patients who have these diseases who are ANCA-negative. It's a minority, but they're important to recognize. So then we talk about ANCA-associated vasculitis, but then you might lose some of the recognition of the name Wegener's and PA. And of course, then you're talking about ANCA-negative, ANCA-associated vasculitis, and you lose everybody. And systemic necrotizing vasculitis doesn't really capture, it's a little too broad. But complicating all that is an issue I just want to briefly mention because it is an area of ongoing concern, which is the use of the Wegener eponym. This is an area of increasing attention by our professional organizations. There is now substantive evidence uncovering a link between Dr. Wegener and the Nazi regime. To summarize that complicated topic, he was, in addition to being a party member, which was more than half of physicians were, and that was, they often lost their jobs if they were not. That was not considered to be a particularly egregious, it's not good, but it was not an egregious event. But he was actually went further. He was a member of the Brown Shirts. He was a very early adopter as an adult to the National Socialist philosophy. And he was also the medical director of a very large region in Poland as part of his service to the nation in the war. And as a physician, he was a pathologist actually. It was considered inconceivable that he did not know what was happening in the Lodz ghetto, which was part of his authority, and the atrocities that were occurring. And there has been a call to remove the eponym. Actually, this call did not start from rheumatology. It actually has started in other areas as well. The American Thoracic Society has removed, took away a Lifetime Achievement Award for him posthumously. And there's been a lot of discussion about this in nephrology, rheumatology, and chest physicians. The work has really been uncovered by my friend and colleague Eric Madison at the Mayo Clinic. He's chairman of rheumatology there. You may know him for his work as an RA in vasculitis, but he's also a medical historian. And Alex Woiwut, who is a physician in Germany and now is in the UK. In the work doing medical history, they actually weren't looking for this evidence, but they came upon it because the Germans kept very good records, and they have they've translated, Eric is fluent in German, and they've translated many of the original documents documenting this evidence. The question is that enough evidence to change things? And there's a group of people in both Europe and the US, Americans, non-Americans, Jews, non-Jews, that are thinking that this should be changed, much in the way we've done it for other names. It's a controversial area. There are people alive who knew and admired this man, so it is difficult. The status of this right now is that editors are interested, but it's at the highest forms of leadership with the American College of Rheumatology and the European League Against Rheumatism, and I think you will hear about this as we go on. So, the problem, of course, is that there's no name to replace it. That's a separate problem from the moral issue, should you change the name. We, as a community of physicians who treat and research vasculitis, will come up with a replacement, should that be called for. So you'll see us use these terms somewhat interchangeably. It's still an iconic term, and it's hard to not use it since it's in the literature. Let's talk about a case. After that, it's more somber. But let's talk about Ms. H. Patient of mine is very representative of the cases we see, and you've seen patients like this, I'm sure. A 40-year-old woman who presented with dyspnea and mild renal insufficiency. She had several weeks of red eye, which was later determined to be episcleritis. She had sinusitis and rhinitis symptoms with discharge and epistaxis. She had purpuric skin lesions. She was progressively dyspneic, twice treated with antibiotics for pneumonia. Not surprisingly, did not improve since that's not what she had. She was transferred to Boston Medical Center at Boston University, where I work, and she was noted to have hemoptysis. She had red cell casts in her urine, and her creatinine was 1.5. She's a big woman, not considered to be that bad, except when you realize that her creatinine 2 weeks ago was 0.9. She was later found to be ANCA positive with PI3 antibodies, and she has ANCA-Associated Vasculitis with granulomatosis, or Wegener's. This was her chest x-ray, not hard to see. This is bad. This is pulmonary hemorrhage. You can see, without even a CT, you can see the, trying to get my pointer up here, but you can see on the right side of the chest, almost full alveolar filling with blood, as well as in the right lower lobe. This is bad. What's missing is the endotracheal tube, which she was very close to getting and being intubated. This is pulmonary hemorrhage. This was her kidney biopsy. You can see this is early crescentic glomerulonephritis. There's even a giant cell on the left upper side of the left panel, and this is rapidly progressive glomerulonephritis. This is the pathology you see in these diseases. Pauci immune, meaning it's not lighting up on immunofluorescence the way lupus does, crescentic GN. What did we do? We treated her. We gave her high-dose glucocorticoids, pulses for 3 days, and then 1 milligram per kilogram daily in a tapering dose. She got daily oral cyclophosphamide, the treatment of choice, which we'll talk about in a second, whether it's still the first treatment of choice, for 4 months, and then transitioned to weekly methotrexate, so-called step-down therapy. And we gave her TMP sulfur PCP prophylaxis. She did great. Pulmonary lesions resolved. All of her other symptoms resolved. Her creatinine went back to normal in several weeks. It sometimes takes even longer than that. She was in full remission. This was her x-ray 2 weeks after that last one I showed, essentially a normal chest x-ray. Very few things in life get better this quickly. Pulmonary edema can, eosinophilic pneumonia, you heard about that in the next talk, and blood. She also gained 40 pounds, which I can tell you she was not pleased about. She lost a lot of hair, although it did grow back. She became menopausal, a big problem with our patients, not just either early menopause or ovarian failure and fertility issues. She also had a recurrence of her disease 18 months later. We had to give her cyclophosphamide and prednisone again, and then maintained her on azathioprine, which she was on for 2 years and then flared again while on 250 milligrams of azathioprine, which she was taking, purpura, arthralgias, hematuria, third course of cyclophosphamide, third course of steroids, kept her on mycophenolate this time, and some low-dose glucocorticoids. She has done well since then, but it has taken its toll, the weight, the other issues, the anxiety, concern about her disease. What can we learn from this case? Delay in diagnosis is common. Weeks, months, even years for some forms of vasculitis, especially this form, can happen, although usually it's not that long. ANCA-associated vasculitis, Wegener's, or microscopic polyangiitis can be, and often is, and will be, if not treated, organ and life-threatening. That is the majority of untreated cases. Remission is obtainable. Remission is the standard. It is the goal. It is the expectation. Nothing less than that is satisfactory at this point. We sometimes have to settle for that, but most patients can be put into remission. Unfortunately, most patients relapse. The majority of patients, more than 50%, in some series, if you follow them out further, 70 or more percent, will relapse at some point, even on immunosuppressive therapy. This is basically a chronic disease. We've taken it from a very lethal disease and now made it a chronic disease. Therapy is toxic, but the disease is toxic. The cumulative burden of disease for the patient is considerable. We do very well. We do much better than when many of us were practicing before we ever used methotrexate for this disease. We do much better, but we still need to do better than this. And would rituximab have changed the course of illness? Might have changed what you got. We'll talk about that. So just to remind you the spectrum of these diseases, we talk about Wegener's, again, the term goes back and forth whether we should use it, is granulomatous and necrotizing vasculitis of small to medium-sized arteries. We see glomerulonephritis is common, and ANCA is present in 70 to 90% of patients, although ANCA-negative cases certainly still do exist. Mostly PI3, but not always. They can be MPO positive as well. Microscopic polyangiitis, a very close cousin. Necrotizing vasculitis involving small vessels. Glomerulonephritis and pulmonary capillitis are extremely common. ANCA is usually present, 90+% if you have renal involvement, usually MPO, but not always. And the upper airway and granulomatous disease doesn't occur, and that's how you sort of separate it from Wegener's. Sometimes we think people have MPA, and then they show up with their nasal and sinus disease, and or they have a nodule, and we say, oh, actually it's Wegener's. We treat them the same. That may change over time as we learn more about how to prognosticate. Churg Strauss is on the list because there's a lot of overlapping features, but as you know, that's pulmonary infiltrates, eosinophilia, and asthma. We'll let Dr. Specks talk about that because there are a certain amount of ANCA positivity and overlap with these disorders. This is a very systemic disease. It can hit, it's like lupus, where can Wegener's hit? Everywhere. ANCA-associated vasculitis can hit almost every organ system, but, you'll see it, if you see enough of this, we see hundreds of cases, you'll see everything, and you'll still see new stuff coming in the next week. But the big three are still the big three: upper airway, lower airway, and kidneys. Upper airway, basically anything can happen. Nasal septum and the sinuses, destructive or just incredibly annoying. Long-term, chronic, recurrent problems. People with upper airway disease have a lot of recurrent airway disease. Sub-Glottic Stenosis is a feared complication, often missed, often ignored until it's very late and the patient gets a trach. Any hoarseness, anybody with stridor, unexplained dyspnea, you really need to look. Incredibly low threshold to have direct laryngoscopy. CT scan's good. Flow volume loops are not good. You can definitely miss things if you don't look directly. Mastoiditis, conductive hearing loss, big problem. Upper airway disease is a nagging recurrent problem. Pulmonary disease, if it's in the chest, it can be affected. Big ones are nodules and, of course, alveolar hemorrhage, which is what kills our patients early on. That is the killer early on, if we don't assist with infections. But anything can happen in the bronchial tree and in the pleura, etc. Glomerulonephritis is also the other major most serious complication, and it's especially problematic because patients don't have symptoms. They don't come in and say, doc, my nephrons are killing me today. They actually might be, but they don't hurt them. And so the point is vigilance, vigilance, vigilance. I have patients dip their urine between visits, report back, get regular tests. You have to keep your eye out. If you're complacent, you may miss the renal insufficiency. A little new hematuria, that's not normal. The only time it's normal is there's some other reason, if it's menstrual flow, or if they have a stone, which they should be so lucky, and it's not from their bladder, or it's from the kidney, or it's from the cyclophosphamide toxicity. Neuropathies are missed regularly. Sensory neuropathies are common, and I think they're missed because of the other things going on. Do a full neuro exam, really get a sense. Motor neuropathies are not missed, but they're devastating. And sensory neural hearing loss, I just want to put a point in for that. Two types of hearing loss, conductive and sensory neural. You can have both. I'll show you that in a second. It's a cranial neuropathy. It's a big problem. Arthralgias or arthritis, very, very common. Fatigue, malaise, very common. We don't do well with that. All sorts of things in the eye can get inflamed. The retroorbital pseudotumor, a particularly difficult problem to treat. Lots of skin lesions beyond purpura, nodules and other things. Gangrene is not that common but can occur. Venous thrombosis, a complication. Actually, my group was the first we described and showed the increased incidence, and in fact, that's badly confirmed, is now considered a part of the disease. Increased incidence of DVTs and PEs. Cardiac and GI disease, thankfully, not common, and of course the laboratory studies, which we'll talk about. Alveolar hemorrhage, I think I've already hammered that in. Not good to fill up your lung with blood. This is another patient with sort of on one side, it doesn't have to be symmetric by any means. And here's a young woman who I followed for years, who's been on prednisone on and off throughout her educational life, who actually has very subtle, you can see the very subtle, here, very subtle changes of alveolar hemorrhage that was confirmed on bronchoscopy. It's not always that traumatic. Probably people walking around with it sometimes. We think of it as people who come in and are coughing up lots of blood and go to the ICU, which is a good place for them. But it can be subtle, and you don't want to miss it. And it's often difficult to differentiate from other interstitial diseases. This is alveolar filling, though. Glomerulonephritis, get a good pathologist, make sure you know what you're looking at. This is a bad problem, and it can cause significant long-term morbidity. Gangrene can occur as a dorsal pedal artery that's essentially gone, and this was actually the first manifestation of a young woman who also then presented with nasal and pulmonary symptoms. Scleritis, work with your ocular immunologist, work with a good ophthalmologist who understands about inflammatory disease, and accept the fact that you don't, and I have, and try to have them help sort out what's episcleritis, scleritis, what's going on. Conjunctivitis, annoying and common. Sub-Glottic Stenosis, Bob Lobovic, who I think is in the room, beside this picture, really the world's expert on how to address this issue. It's not always this dramatic, but it requires specialized care for dilation, injection therapy, and you have to know what you're doing. Pulmonary nodules, incredibly common. These aren't new. These are old. This guy's fine. And that's another important thing to remember. Nodules may be new, they can bleed, they can cause cough, they can cause all sorts of problems. They don't usually hurt, and they don't usually cause dyspnea unless there's a lot of them and they're big space filling. But they're a problem, and they often scar down and don't go away. You've got to know where you're at. I stage the patients, Mike was talking about staging, regularly. You need to know where they've been and where they are now. So you might get that scan, a diagnosis, and I repeat it at the time of transition of therapy, because this guy's going to have this forever, actually. This is when he looks good. And this is as healed as they're going to get. And I need to know that, so if he has a cough down the line, I'm not treating a nodule that's really old. On the other hand, I also want to know what's new. Mononeuritis multiplex, bad problem. Neuropathies, devastating problems. Ulcers, annoying, pretty common. These little skin nodules are common. They're not purpura. You'll see sort of granulomatous, other kinds of inflammation. They're pretty common on the elbows and other places. Upper airway, it's all over the place. Lacrimal gland involvement, very problematic. People have tearing, they block their lacrimal ducts. Sinus disease, biopsies are usually not diagnostic, but you'll see a lot of stuff. You have to obviously rule out infection, and often they can coexist. Saddle nose deformity is a feared complication, can be corrected with surgical plastic surgery, can help when done properly, and this could be a devastating problem. This guy has saddle nose, that wasn't his problem that he was worried about. He also has a very subtle right orbital pseudotumor. You can see a little bit of proptosis, and if this is a very nagging, difficult problem to treat. Gets better with steroids, comes right back. Hearing loss is very common. I guarantee you're missing it if you don't get audiograms regularly. We have some data I'll show you in a second. Sensory neural hearing loss can be scarring and often doesn't recover. Conductive often does recover if gotten pretty early. Mixed hearing loss means you have both. Audiograms are cheap and easy and a nice objective way to follow hearing. We get creatinines, we get chest x-rays, we should be getting regular audiograms. Hearing loss in your older patient with vasculitis may well be vasculitis and not just presbyculosis. We did a study actually at our center and showed that there was an increased incidence of hearing loss, and if you look more, you will find it, and it's an important thing to follow. Ask them about hearing. Are they turning up the television? Are they having trouble with their phone, etc.? As I like to say, though, you have to differentiate that from the selective spousal hearing loss that many of us have, where you can't hear your husband or wife, which I think is evolutionarily helpful, but otherwise, if the hearing loss is happening, you need to hop on it. There is more to acute vasculitis than you think. If you look for trouble, you will find it. And that's important because as with lupus and other things, finding badness changes therapy. You're going to treat the worst aspect of the disease. You need to do a full inventory of your patients at all times to know what you've got, what they've had, what's old, what's new. So, this is sort of like telling, I know this is pretty basic, but do the full history physical. This is not a 20-minute visit. Okay, this is 90 minutes in my office to start with a new patient, usually under 2 hours, the fellow goes in, etc. This is a complicated thing. Do the full history and physical, get a full set of labs. We'll talk about what that means. Do a urinalysis. If you're worried about kidney, if they have this disease and they have positive protein or blood, you need to spin the urine and look at it. I do it regularly in my office. Chances are you may not be comfortable. You don't see enough glomerulonephritis in practice. You might not feel comfortable. Get someone who is. The lab will never see the cast, ever. It's not what they do. It's not what they're trained for. The urine gets old sitting around. You've got to follow the urine. ANCA, we'll talk about its role, obviously very important diagnostically. Chest x-rays are good, CTs are better. We'd like to cut down on the amount of radiation, so you have to sort of be parsimonious almost, but CTs really give you a much bigger picture. We constantly see people who have lesions on CTs missed on plain chest x-rays. I would do an inventory and stage everybody at baseline. You don't need contrast, almost never need IV contrast for these images for either the head or the chest. An audiogram I've already discussed. An ENT, partner with your ENT doctors, he or she should be able to help understand active, inactive, what's going on. Biopsies are still very important diagnostically, especially when you're trying to sort things out. I would argue they're even more important diagnostically later in the disease when you're trying to figure out, is that nodule, is that an infection, is that a tumor, or is that their vasculitis again? And sometimes nerve conduction tests are useful. I actually think a good exam is probably better. Nerve conduction studies, the EMGs, are painful and annoying, but they can be helpful at times. Don't miss the comorbidity, especially infection. These are rare diseases. Not necessarily my clinic, but that's what I specialize in. These are rare. Make sure you're not missing something else. So rule everything else out. What about ANCA? Everybody loves ANCA. It's changed the field. ANCAs are incredibly helpful diagnostically. The sensitivity, the specificity for ANCA in the right clinical setting is 95% or higher, which is better than most of our serologies that we use. It's not perfect, but in the right setting where you have a moderately good pretest probability, it's extremely helpful. If you get the right kind of ANCA, immunofluorescence with ELISA, you have to have the combination. The lab has to know what they're doing. The sensitivity is not as good. It's thought to be 70%. I think it's actually higher than that, even in non-renal Wegener's when you have proper testing. But there are still patients who are ANCA negative will have it, especially if they don't have renal disease. As I said before, in MPA, it's most likely to be positive. Don't overly rely on ANCAs. Certainly have Wegener's and MPA, or even Churg Strauss without ANCA, certainly Churg Strauss, especially if non-renal alveolar hemorrhage. False positives occur, and you still need a biopsy if you're not sure exactly what's going on, or if you think there's a comorbidity, or if the patients are coming back and now it's a problem. Do ANCA titers measure disease activity? I will very briefly talk that this was extraordinarily controversial. We really wanted them to track with disease and help predict flares. But now the data was there early on, a lot of promise for the ANCA titers. More recent data indicates no. I don't have time to go through all of the data that supports that statement, but I know that almost all of the speakers at our meeting and the overall meeting will agree with this at this point. This is a meta-analysis from my group that is under review that just gives you a sense of looking at the various quality studies, looking at ANCA as a predictor of flares, if they rise in ANCA. And when we put it all together in terms of a likelihood ratio, which is a very good system for practical aspects, we find that while there is a positive likelihood ratio of about 2.9, meaning there's a hint that if the titer is going up, they may be flaring, it is actually pretty low in terms of changing decision making, and it wouldn't substantially change your clinical decision making. And the same for a negative one. And so the consensus opinion is ANCA titers are not predictive of flare. Don't treat the ANCA titers. Treat the patient. Are ANCA pathogenic? Well, we could have a long discussion about that. I would say with absolute certainty we don't know. And the pros are that the clinical correlations, they're obviously extremely prevalent. They're fantastic animal models looking at this, with fusion of ANCA and transfer of ANCA, and they get disease, the animals get disease that looks very much like human disease. There are some interesting ANCA-neutrophil interactions. On the other hand, it clearly doesn't explain all the diseases. Why are there two types? It doesn't all fit. And so stay tuned, it may play a role. What does cause ANCA? What does cause the vasculitis? We're not sure. The theories are the same for all of our diseases. Is it an environmental stimulus? We certainly haven't found one. Is there an infectious trigger through this upper airway, lower airway entry? Maybe. Is it molecular mimicry that later on you get an exuberant response? Is there a genetic predisposition to autoimmunity? I think there is for many of our diseases, but it's clearly not like sickle cell and cystic fibrosis. But I think we will learn from genetic studies if there's genes that help make you more likely to have disease or more likely to have some the particular manifestation. There is evidence for humoral immunity, cellular immunity, and almost certainly there's a combination of the two, maybe differently at different phases of disease. What about treatment? The rest of the talk will talk about treatment. Glucocorticoids remain key for the acute treatment of ANCA-positive vasculitis. Nothing works as quickly. This is what saves patients' lives and kidneys in the short term when they have very severe presenting disease with hemorrhage or kidney involvement. Don't delay when there's pulmonary hemorrhage and RPGN. Start the steroids. It won't affect your biopsy if you go quickly. This is one of the few situations, I think, when rheumatologists are going in and saying, hey, please start the steroids. Usually we're going in and saying, stop, what are you doing? And so this is a time to really think quickly. You can usually wait until the patient is more stable to start other immunosuppressives to some extent. But don't wait too long, because we know that glucocorticoids alone are not enough. You need to add an immunosuppressive agent, because there might be a small minority of patients you don't, but we don't know who those are. Two reasons. One is it's just simply not enough. People flare and continue to have disease even when they're on steroids. And two, you just can't keep people on 60 milligrams of prednisone every day. It's just too toxic. Standard therapy for severe cases of ANCA-associated vasculitis. We talk about remission induction phase, get them into remission, no evidence of active disease, and then transition to the maintenance phase where you maintain them on an agent for an extended period of time. Cyclophosphamide remains the gold standard. We'll talk about in a second how that may be changing. Cyclophosphamide, severe disease, either IV or oral. We'll talk about that in a second as well. And then we're now going to shorter and shorter courses, 3 or 4 months of cyclophosphamide, taper the prednisone. You'll notice the glucocorticoids on the side, big doses, tapered steadily, and then transition to either azathioprine or methotrexate. There are good data for the use of azathioprine and methotrexate. They're fairly equivalent. There is some data to say mycophenolate is the third choice and is not as good. And of course, experimental options. The question now is there a new standard as of 10 days ago when we published the Rituximab and ANCA-Vasculitis trial, the RAVE study, and the European study of Rituximab as well. I'll speak about that in a second. And I think it is now another standard of care for remission induction. Plasma exchange, or PLEX, has a role. We're not sure what it is. I'll tell you about a study we're doing. Some mild flares of disease, you just give a little extra prednisone. A little bit of prednisone is very helpful. Often what we're doing is we're going up and down, but most of the time we're not treating it just with prednisone. This was a landmark study from now several years ago by the European group telling us that you can step down from cyclophosphamide. Instead of going it for 12 to 18 months, they looked at a regimen where they had everybody got cyclophosphamide, and then after 3 to 6 months, they were randomized to more cyclophosphamide or azathioprine. And if azathioprine was as good, then the remission rate should be the same. And what they found is that the two arms did equally well. You could also turn this over and say, well, actually, that's a pretty, even at 12 months, over 10% of patients came out of remission. And after 18 months, it was closer to 20%. So again, we don't cure everybody. We don't treat everybody that effectively. But this tells us that you can use azathioprine as maintenance. These studies all show that you can use methotrexate for maintenance. So I'm not going to go through all of these. Step-down therapy, remission with cyclophosphamide, maintenance with methotrexate or azathioprine. Give it for 3 to 6 months of cyclophosphamide and then transition. It has been the standard of care for some time now. I usually wait till the prednisone is less than 20. I try to get that down quickly within 3 months before I make the switch. The decision between methotrexate and azathioprine is kind of a toss-up. They're probably equally efficacious. There's been a trial that shows that, and it's individual patient issues, as we know well in our practice. Again, the new data on rituximab may change all this. For non-severe cases, for people who don't have major organ system involvement, this may still be pulmonary nodules, arthritis, rhinosinus disease, even some hearing loss that's not neural. It's still serious disease, but they may do well, or maybe hematuria but not a rising creatinine, they may do well with methotrexate alone. It's actually a subset of patients, minority of patients, but it's still maybe 20%, that's a ballpark figure of people who present. It depends if you're a rheumatologist or nephrologist, what more likely you're going to see this. Methotrexate can be used for induction and continued remission in those patients. Just keep track. When you're going to use this drug for induction, push it to fairly high doses. We start at 15 and go to 25 regularly, including in older patients. I'm very leery of using this in renal involvement. There's mixed data. Some people would use it regularly. I'm concerned about it. And obviously, you can't give it to all patients for a variety of other reasons. It's probably not as good as cyclophosphamide in general, but it's certainly less toxic and it's a good option. Just because it's not as good doesn't mean it's not a good option to try. Remember, the key thing is you're following the patients very closely. So if there's a problem, you can intervene. Mycophenolate. Small open study showed some partial benefit. Nephrologists, any nephrologists in the room? Identify yourself. Okay. Don't worry. Actually, I married a nephrologist, and I'm still married to her, and so I like them. The remarkable thing is that she's still married to me, but that's a separate issue. That's a psych issue. Nephrologists love this drug because it works so nicely for transplant, but that doesn't mean it's going to work in this disease. The onset of action may be a little bit faster. This is some unpublished data that my colleagues in Europe were happy to lend to me of the IMPROVE trial, which actually does have a reason why it's called IMPROVE. I won't go through the acronym, it's a long one. This was a trial of mycophenolate versus azathioprine for remission maintenance. So everybody got glucocorticoids, everybody got cyclophosphamide. Notice the trend here. Everybody gets steroids tapered off, everybody gets cyclophosphamide. After remission, they were randomized to mycophenolate or azathioprine at these doses, which are pretty good doses. You could argue about the doses, but the fact is, the goal was to see how did aza do against mycophenolate. And the answer is, this is incidence of relapse, and the red line is mycophenolate. The answer, surprisingly, was that it actually did worse. Statistically significantly and clinically significant, less likely to keep people in remission than azathioprine. Maybe it's the dose, you should go higher than 2 grams, but this was the study done. It was a good study, and I think this should tell us something. This is a third choice after the other 2 agents, methotrexate and mycophenolate, but it's still effective. So there's actually an ongoing study of mycophenolate for remission induction, head-to-head, mycophenolate, cyclophosphamide in Europe. That's a bold study. We'll see how that goes. A little bit of prednisone goes a long way. A lot of patients need 5 to 10 milligrams of prednisone to maintain comfort from sinus and nasal disease, from arthralgias, from other things, from skin problems, even in the face of other immunosuppressive therapy. This is just like RA, the dirty little secret of RA. A lot of patients still need their 5 milligrams of prednisone, and lupus. I don't know why, but it's true. What about B cells? Get it? Bees, cells? Okay, so what about B cells? Why rituximab for ANCA-positive vasculitis? Rituximab, of course, is the anti-CD20 monoclonal antibody. Treatment results in complete B cell depletion. You give this drug, the B cells are gone, at least peripherally. What's happening at the tissue level is of interest. Why target B cells? The source of ANCA? Well, plasma cells are, but they talk to each other. There's an array of other effects: antigen presentation, cytokine production, crosstalk with T cells, and encouraging lab, animal, and human data. So, after an initial pilot study that Dr. Specks conducted at the Mayo Clinic, he then led us in a multi-center zillion-year study that we conducted for 197 patients. This was published 10 days ago in the New England Journal. This was an important study at 8 sites internationally. What did we find? First of all, what was the study? We took patients with severe organ or life-threatening disease. They had a severe manifestation that normally we would always use cyclophosphamide for. We took those, they had to be ANCA positive. We went for 200, but we ended up with 197. That's pretty good. Everybody got high-dose prednisone, methylprednisolone, and then they got high-dose prednisone in a standardized tapering fashion. However, they were randomized. Either they received cyclophosphamide, 2 milligrams per kilogram per day, which is the standard oral dose, and placebo infusions, or they received rituximab in a 4-dose regimen, the lymphoma regimen, 375 milligrams per meter squared once a week for 4 weeks, different from what you're using in RA. And they got cyclophosphamide placebo. Complicated study, double blind. We had patients who were had, so we didn't see if they lost hair. We had different people evaluating them, but we maintained the blind. So basically, you got cyclophosphamide, and then you were transitioned to azathioprine, as per normal standard of care here on the left side of the panel, or you got rituximab, and you didn't get anything else. And the goal was to see what happened at 6 months. There were some safety things. We crossed people over. If they didn't go into remission, we wanted to make sure we took care of everybody properly. And then there was an open label component. The data we have now is just for the 6 months. Those other data will be very important to helping us figure out how to use this drug. What did we find? Well, the goal of the study was to see if rituximab was equivalent to cyclophosphamide for the induction of remission. And we did indeed find that. At 6 months, the number of patients in complete remission and off prednisone, a pretty high bar, was 64% in the rituximab group, 53% in the cyclophosphamide group. These were not statistically significantly different. There's enough overlap, but we have achieved the primary outcome equivalent. First drug in 40 years to show that it was equivalent to the use of cyclophosphamide. If we allowed some patients to get a little bit of prednisone, I told you need a little bit, the rates went up, but it's still equivalent between cyclophosphamide and rituximab. I would urge you not to look at the differences too much. We consider these to be equal findings. However, there were some subgroups of interest. Patients with new disease, the two panels on the left, very equal ability to get into remission. Interestingly, patients who have had recurrent disease, so a flare, these were patients who previously treated I think all of them had been treated with cyclophosphamide in the past. Interestingly, rituximab was particularly efficacious compared to cyclophosphamide for that subgroup. This was a preordained analysis with a significant p-value and, more importantly, a significant clinical difference. The adverse events were essentially not different between the two groups, but I would remind you, we do not have long-term outcome for either cyclophosphamide or rituximab for these patients. Many of the bad things, cyclophosphamide, come later, although many of them come early with infections. And rituximab, the question is what's going to happen long-term. One thing was different, leukopenia. Not surprisingly, patients with cyclophosphamide had more leukopenia. That did not translate to more infections. What's our conclusion? Rituximab represents the first proven alternative to cyclophosphamide for remission induction in severe ANCA-Associated vasculitis. This is big. This is a very, very important trial. This is of particular importance to patients who present with severe disease flare, recurrent disease, and patients who want to preserve their fertility, which in many of our young patients. It also may be very important for new patients. How are we going to use this? Let me just mention there was another study published in the same issue of the New England Journal, a smaller study by our European colleagues, 44 patients in a randomized open-label study, a little more complicated. One group got rituximab and 2 doses of cyclophosphamide because they were a little concerned about giving rituximab alone. The other group got just cyclophosphamide. They also found, it's a little bit confusing, but essentially, because the numbers get very small after a few months, the rate of remission was the same for both. Confirming what we showed, we could argue we confirmed what they showed. We like to think they confirmed what we showed. And their adverse event profile was also similar. Okay, my take, and this is changing daily, on the role of rituximab in the treatment of ANCA-Associated vasculitis in 2010. It's the first new treatment in 30 years for induction of remission of severe disease. It can certainly be used instead of cyclophosphamide for remission induction in selected cases. You have to have a conversation with the patient. It may be particularly useful in cases of relapsing disease and in patients for you really are very eager to preserve fertility. The unknowns, of course, is what is the long-term benefits and risks to rituximab? What are long-term benefits of our other treatments as well? When, how, who to retreat? What do you do in 6 months? Do you put them on azathioprine? We didn't test that. Do you wait till their B cells are back and redose it? We'll see. Do you wait till their symptoms come back? Is that too late? Data, we will have some data on that, but that are some of the unknown questions. What does it mean to be on rituximab for many years? We'll try to figure some of that out. And you should know that there's a subset number of people who didn't go into full and sustained remission. Some of those were mild and could be handled with other ways, but some were serious. And so it's not a drug it's not a cure, but it's another great alternative. And there are still roles for cyclophosphamide. So, the new standard of care, cyclophosphamide, either oral or IV, and rituximab. And then transition or not. The question is, do you need to transition to something else if they've been on rituximab? We don't have time, maybe at the panel, to sort some of that out. This is another option. There's payment issues, well, I recognize that. But I can tell you, with the data out, if you include the article in your letter to the insurance companies, you will win if you push for the use of this drug. The most important part of treatment, however, remains close, frequent clinical follow-up and monitoring. Nothing replaces that. Nothing replaces. You cannot, you are married to these patients forever. I see the patients at least every 3 months. You need to see them face-to-face, what's going on, have their labs done, etc. You need to also follow up. Here's a young man who was involved in one of our studies who didn't follow up after 2004. We begged him, he got into remission, he got off prednisone. We said, you got to follow up. We sent letters, we tracked him down, went off to Europe, and in fact didn't get follow-up, came back and he went to see a PCP for some other problem and is found to have a creatinine of 7.5. He's now waiting for transplant. I think we could have prevented this. We still have unmet needs. We still need to have rituximab is going to go a long way to help with cyclophosphamide sparing, but it won't be for every patient. We still need to know about what can we do during pregnancy, and we got to get people off glucocorticoids. We use too much. It's just to figure out how to do that. We need to prevent relapse. Relapse rate, including with rituximab, is too high. We need to figure out strategies, and I think we will. These are happy problems to address. It means we're doing better with the other parts of the disease. We need to treat exceptionally resistant disease, and we need to be able to figure out the mild to moderate, smoldering, annoying, upper airway continued disease that requires 15 to 20 milligrams of prednisone. I see Dr. Weissman stalking, but he's going to have to wait a few more minutes. I still have my 7 minutes, and I'm going to use them, damn it. So we still need to figure out the treatment of resistant disease, and we need to advance in non-drug therapy, surgical. You've got to be very careful when you do surgery in the eye, in the trachea, and elsewhere. A lot of experimental agents still on the horizon. Mycophenolate, I told you about ongoing investigation. Some disappointment recently. Anti-TNF, I don't think is going to be investigated in any kind of comprehensive fashion in the future because of issues we've had with negative studies. B-cell, continue to investigate. We've got lots of data to analyze in the RAVE study. We're going to be doing that for years. There are cohorts elsewhere that are being evaluated, other studies that are ongoing for the use of rituximab, and there are other B-cell depleting agents that are out there that may be under investigation. We have a T-cell study going on. We're looking at abatacept in mild to moderate disease. The study is now closed for enrollment, but we'll be able to analyze that. This is through the Vasculitis Clinical Research Consortium that Carol Langford mentioned. This is a multi-center that all of us are involved with. I happen to have the privilege of leading this, and this is a trial that is looking at this as a pilot study. And there's some reasons to believe T-cells may be important. We'll see where this goes. Plasmapheresis. An important study in the world of plasmapheresis was this study in 2007, so-called MEPEX trial. Very quickly, this was all renal disease, bad renal disease. ANCA-positive vasculitis with creatinine of 500 micromoles, which is 5.7 or worse. Very bad renal disease. You couldn't have alveolar hemorrhage. You got randomized to pheresis or no pheresis. And here you see that the patients who got pheresis were less likely to go into renal failure than those who didn't, but there was no difference in mortality, and the mortality rate was high. At 12 months, it was 25%. That's high. And so the question has become, is pheresis really effective? Maybe in the severe renal presentation. I'm going quickly through this. This is a meta-analysis that I've been part of that is looking at all the different trials, of which it is fairly messy and somewhat sloppy data, but our conclusion is that there is some modest benefit for renal preservation, but when you actually combine it with death, this is death, there's no benefit, which is a little bit weird because it should prevent death because we know renal failure is a problem. None of these studies effectively looked at alveolar hemorrhage or other manifestations of disease, and they mostly looked at very severe renal disease. So, in 2010, if you're anti-GBM positive, which you should always check in your patients who have glomerulonephritis and pulmonary hemorrhage, then plasma exchange is effective and should be used. You might consider it for severe renal disease as per the MEPEX trial. You can certainly look it up, or you can contact me. I'm happy to give you advice about how to do that. And you consider it for severe alveolar hemorrhage, but there's no data to support that, and I tend to wait to see how they respond. We need to have a trial, and we do have a trial. So I'm one of the three principals who are running this study, the plasma exchange trial. Be happy to know that Dr. Weissman and his group will be a study site for this as well. This is going to be a 500-person trial of ANCA-Associated vasculitis in multiple countries and multiple continents, looking at the question of plasma exchange versus no plasma exchange. It is funded through the FDA and through the UK government, as well as now funding from Canada and Australia, and it's a combination of the Vasculitis Clinical Research Consortium and the European Vasculitis Study Group. What we're trying to see is two questions, actually. I will skip to this. What we're trying to see is everyone gets standard of care, cyclophosphamide or rituximab, and actually written in rituximab into the protocol, and they either get plasma exchange or no plasma exchange, and we follow them to see how they do. We feel this is ethical because it has not been proven that plasma exchange is useful, but we need to know the answer. We have another factor, it's a factorial design. We're also looking at standard dose of glucocorticoids and then lower dose because we think that we could probably reduce, but we need to prove it in a trial. If you have a patient with new onset hemorrhage or renal disease, even moderate renal disease, transfer them to Cedars-Sinai. Dr. Weissman will be happy to enroll them in the trial and let you know how they do. That's the only way we're going to get answers to these questions. These are the countries all over the world who are involved in 4 continents. This is a busy study. It's funded by lots of different ways. I don't have time, but perhaps in the questions we'll discuss the issues of infections. We immunosuppress our patients, look for infections, anticipate them, make sure you're not treating infection when you think you're treating vasculitis and vice versa. PCP prophylaxis is still required, is still important. Anemia, patients with renal insufficiency especially, they may need erythropoietin, work with your nephrologist, get that for them within moderation. TPMT testing is essentially standard now if you're going to use azathioprine. Osteoporosis prevention, of course, we're good at that if you're a rheumatologist and hopefully nephrologists as well. And the whole issue of teratogenicity and sterility remains a big issue. I have patients who still talk about sperm banking, now egg banking may be available. These are very important and sensitive issues. I want to we have had support for the trials I've mentioned from multiple institutes at the NIH, other federal offices, the FDA. The Genentech has been a great partner in funding the ARRAVE study. Bristol Myers is helping with the Avitesov study. And the Vasculitis Foundation, American College of Rheumatology, and others are funding the research in vasculitis. There is more clinical investigation in vasculitis now than ever before, and I think it's bearing fruit. We're getting some real answers. So I will end on that. Thank you. I'm sorry, I was 60 seconds early. Is that okay?
Ulrich Specks from the Mayo Clinic. It's a pleasure to have him here. It's a pleasure for me to meet him for the first time. We're on the very much home stretch, and then we'll have our panel meeting right after it. So sit tight. Here we go.
Well, thank you for inviting me for this vasculitis symposium. And as we come to the end of it, I have to warn you, we're now leaving the field of data, and we're going into the field of pure anecdotes. Because clearly, Churg-Strauss syndrome is the rarest of the diseases that have been looked at here today. And as a result, we don't have real good clinical trial data results in contrast to the ANCA-Associated vasculitides we've talked about before. Disclosures, everything we're talking about is off-label use of the medications, no financial disclosures with respect to this talk. Churg-Strauss syndrome carries the name of Jacob Churg and Lotte Strauss, who first described this disease based on autopsy studies in 1951 and coined it allergic granulomatosis and angiitis. And this is probably a very accurate and good descriptive term for the disease that captures everything. They observed in high mortality, of course it was an autopsy study. The estimated incidence today is 2.5 to 3 per million per year, so quite rare. Andrew Churg, son of Jacob Churg, introduced the term form Frusts for Churg-Strauss syndrome in the 1990s. And when that term is used, it's generally referred to as a situation where Churg-Strauss syndrome may have been smoldering under the surface for a long time, but has been covered up by steroid treatment for asthma. And once the steroid treatment is reduced or removed, the more classic disease manifestations of Churg-Strauss syndrome may come out, and this is of particular relevance when we talk about potentially drug-induced Churg-Strauss syndrome, as you will see later in the course of this talk. I'd like to address 4 persistent questions about Churg-Strauss syndrome that come back over and over again. First of all, how do we diagnose this? We don't really have diagnostic criteria, but there are classification schemes. How do we apply them? When can we truly assign the name Churg-Strauss syndrome to the disease? And does it really matter? What's the role of ANCA? It's lumped in the group of ANCA-associated diseases that clearly there are not many patients that don't have ANCA. Is there a specific role for the disease phenotype if ANCA is present? Do leukotriene inhibitors or other drugs play a role in inducing Churg-Strauss syndrome? And most significantly for patients, and the biggest challenge, of course, is how should we treat it, and which patients should we treat, how in particular. 3 major components to Churg-Strauss syndrome, of course, asthma, eosinophilia, and vasculitis. Usually, asthma comes first, followed by eosinophilia, followed by vasculitis, but not in all patients does this chronological order occur. The median age of onset is, depending on which study you read, somewhere in the 40s, and it hits men and women pretty much equal frequencies. Characteristic for the Churg-Strauss lesion is the eosinophilic granulomatous inflammation that you see in the left panel A. If that eosinophilic inflammation encroaches and involves the vessel walls, like in the middle panel, you have the eosinophilic vasculitis. It is less necrotic than what we generally see in the necrotizing vasculitis of Wegener's or a microscopic polyangiitis. When you zero in on the inflammatory infiltrate in panel C, you see that most of the inflammatory cells are eosinophils. So eosinophilia is the hallmark of the disease. Depending on how you look at this and what you read, the cutoffs are a little bit different, but it probably doesn't really matter. Usually elevated eosinophil counts is what counts. In addition, you need to see the eosinophils in the affected organs where they do damage. Which organs are most frequently involved? Well, most studies come up with something like this. And on this slide, I summarize two large studies that have similar amounts of patients, one from our center, one from a multi-center study in France. There have since been a couple of other large series that give you the same frequencies. And keep in mind that this frequency of organ involvement and disease manifestations is certainly affected by the definitions of the disease. So as a consequence, it's no surprise that most patients have asthma. Up to 80% of patients have peripheral neuropathies, sinus disease in 2/3 of the patients, skin involvement in half, lung involvement less frequently, up to 2/3. But I want to point out here that alveolar hemorrhage in the context of Churg-Strauss syndrome is exceedingly rare. And when I see a patient with alveolar hemorrhage syndrome, I think of everything else first before I think of Churg-Strauss syndrome. The GI tract is involved in about 30% of patients, and that is much more frequent than in patients with Wegener's, or at least the patients with microscopic polyangiitis that we see. Kidney involvement in 1/4 of patients, and if it occurs, it's generally mild, and it doesn't seem to threaten the kidney quite as much as it does in the other ANCA-associated vasculitides. One exception, the publications that are coming out of the Hammersmith have more severe renal disease, and maybe that's referral bias because that's a nephrology unit that has put out these reports. Cardiac involvement is fortunately not that frequent, but if it occurs, it has quite a bit of morbidity and mortality associated with it, and it is probably overlooked, and we'll get into this into some more extent. Central nervous involvement in up to 10% of patients. So let's look at these individual manifestations in a little bit more detail. Most patients have asthma. Most often it precedes the other disease manifestations. The median time between onset of asthma and full-blown Churg-Strauss syndrome with vasculitis is in the order of 4 years. In our study, in 13 patients of 99, the onset of asthma coincided with that of vasculitis, and in 2 patients, asthma was not present at the time the vasculitis became obvious, and in one patient it actually lagged behind quite a bit of time. So now, can you make the diagnosis of Churg-Strauss syndrome without asthma? Of course you can, but it is exceedingly rare. When you tabulate all larger series, you come up with 12 of 467 patients, totaling up 2.6%. So it is rare, but it can occur. Other pulmonary manifestations, we're talking about pulmonary parenchymal manifestations most often, are the transient, patchy, usually peripheral infiltrates that are, and I'll show you some examples, which are a reflection of eosinophilic pneumonia. Nodular densities, which occasionally can cavitate, are less frequent, and we do see pleural effusions in about 10 to 15% of patients, and when we do tap them, they generally have a high number of eosinophils. So here are some examples for non-asthmatic pulmonary involvement, which occurs in about half of the patients. You see these transient alveolar opacities in this patient. Sometimes you see nodular lesions, and very rarely, as I mentioned, alveolar hemorrhage can occur. You notice that the lesions are generally subtle, and you sometimes miss them on chest röntgenogram. So in Churg-Strauss patients, initially at a diagnosis, we like to get a CT scan. Also keep in mind that radiographically, the infiltrates of Churg-Strauss syndrome are indistinguishable from the infiltrates seen in chronic eosinophilic pneumonia. And when we see something like this in the pulmonary practice, the differential diagnosis is a little bit broader than when the patient first shows up at a nephrologist or in the rheumatology practice, because we have to take into account all the chronic eosinophilic lung diseases that are isolated to the lung, but once you have systemic involvement, you're talking about Churg-Strauss syndrome or maybe hypereosinophilic syndrome, and only have to differentiate these two. Sinus involvement is very common in Churg-Strauss syndrome. It can have more allergic features or more granulomatous features. Actual vasculitis on biopsy is quite rare. And then you always have to deal with a differential diagnosis. Is this just simple nasal polyposis, or are you dealing with an allergic fungal rhinosinusitis? Those usually do not have any other systemic disease manifestations, but at the very beginning, at least to an ENT person, these things can look fairly similar. Neurological manifestations are very common and a central feature of most classification schemes that we're going to get into in a bit. Peripheral neuropathies are making up the bulk of neurological disease, and central nervous system disease, fortunately, is rarer, but if it occurs, it has quite a bit of morbidity and mortality associated with it. In clinical manifestations of this can be ranging anywhere from confusion to convulsions and coma. Cranial nerve involvement has been described, and when you do CT scanning, you sometimes find granulomatous nodules. Skin manifestations are nonspecific. About half to two-thirds of the patients are involved. Shown here is the extravascular necrotizing granuloma, also referred to as the Churg-Strauss nodule. This is, of course, to the rheumatologists known much more frequently from rheumatoid arthritis and Wegener's granulomatosis, where the same lesion occurs probably even more commonly than in the context of Churg-Strauss. It's really a palisading granuloma with central necrosis. Also seen in Churg-Strauss syndrome is palpable purpura, leukocytoclastic vasculitis of the skin, and in the case of Churg-Strauss syndrome, you often find more prominent eosinophils in the inflammatory infiltrate, but clinically it's quite indistinguishable from what we see in microscopic polyangiitis or Wegener's granulomatosis. This is a 37-year-old lady I saw a year and a half ago, Afro-American 37-year-old, present long-term history of asthma, presented to the hospital with worsening of dyspnea, and you can see that the cause of her dyspnea was cardiac tamponade. She had a large effusion. This was tapped and proven to be an eosinophilic pericardial effusion, and they did at the biopsy also a catheter, at the time, a catheter biopsy of the endomyocardium, and they showed a eosinophilic myocardial infiltration. So this is an acute presentation of cardiac Churg-Strauss syndrome in an asthmatic. What about heart involvement? It causes significant morbidity, and it is one of the primary causes of mortality in Churg-Strauss syndrome. Depending on which series you read, it occurs in 10 to 20% of patients, and I'll show you the most recent report that just came out in the last couple of weeks online. No, actually it came out a year ago in Arthritis and Rheumatism, that one. I'll show it to you, which makes the case that we're probably overlooking some of these patients. Myocarditis with eosinophilic infiltration, epicardial vasculitis leading to restrictive or congestive heart failure is fortunately fairly rare. Pericarditis that occasionally can lead to tamponade is also not all that frequent. What is causing the damage are the eosinophils that are activated and degranulate and leave behind their granular content, consisting mostly of eosinophilic major basic protein and cationic protein, and these granule constituents are toxic to the surrounding cells and lead to damage of the cardiomyocytes. Coronaritis is quite rare, was observed more frequently in the original post-mortem reports, but in patients that we diagnose nowadays, this is probably a very rare occurrence. When we looked at our cohort of patients at the Mayo Clinic, we detected cardiac involvement in 18% of patients. Now I need to have a caveat here in that these patients were not all screened up front. They were only undergoing cardiac tests if they were symptomatic and referred for echocardiography and other cardiac studies. So this study probably underestimates the frequency of cardiac involvement. There is a notion, and we'll get into this a little bit more when we talk about ANCA and disease phenotype. There is a notion that some studies have proposed that patients who have higher eosinophil counts are more likely to have cardiac involvement than those patients who have lower eosinophil counts. We looked at this in our cohort, and you see that indeed the patients with heart involvement had a significantly higher mean and median peripheral eosinophil percentage, but you also see at the same time that there is no discriminatory value whatsoever in the eosinophil count when it comes to distinguishing those with no heart involvement versus heart involvement. And this is a study I alluded to, came out in arthritis and rheumatism. I think it was either January this year or I got the year mixed up, but it's been a short while. A study from the Netherlands, which was very rigorous in that it took 32 consecutive patients with Churg-Strauss syndrome and compared them to 32 randomly selected age and sex-matched individuals, subjected everybody to ECG, echo, and cardiac MRI, and found a prevalence of cardiac involvement in 62% of patients with Churg-Strauss syndrome compared to 3% in the controls. Now, when they looked at cardiac symptoms, you're getting more into the ballpark of the numbers that I showed you earlier, namely 26% of the patients with Churg-Strauss syndrome had cardiac symptoms versus 3% in the normal controls. And they also found that MRI scanning was certainly the most sensitive method that essentially detected everybody, whereas echo and ECG had subsequently lower sensitivities. Now, what do you make of that? That's the other big question. I don't think we can draw the conclusion that everybody who comes through the door with Churg-Strauss syndrome needs an MRI scan of the heart. However, I think everybody who walks in the door deserves that we think about the possibility of cardiac involvement, and we think about a strategy of looking for symptoms and discussing with the patients, in our threshold for appropriate testing should be rather low. What about venous thromboembolism in Churg-Strauss syndrome? Again, we did a retrospective analysis of our cohort of 132 patients from 1990 to 2005. We found 17 venous thromboembolic events over the course of 775 person years, leading to an incidence rate of 2.2 per 100 patient years. That's 9 of the 17 occurred in the first year after diagnosis, leading to or translating into a first-year incidence rate of about 7 per 100 person years. And this is clearly higher than the incidence in an age-matched general population, and it is absolutely comparable to reports in other ANCA-associated vasculitides, namely Wegener's granulomatosis and microscopic polyangiitis. And a couple of years ago, a Dutch group confirmed similar data when they looked at the frequency of thromboembolic disease in Wegener's microscopic cholangitis and Churg-Strauss syndrome altogether. What are the risk factors for venous thromboembolic disease in this patient population? Well, age may be. Certainly the age of patients with thromboembolic events was higher than those without thromboembolic events. However, you will see that the confidence intervals overlapped, so this difference is not significant. There was no association of thromboembolic event with eosinophil counts, with the presence or level of ANCA, or with any other specific disease manifestation of the Churg-Strauss syndrome. So this is again one of those things where our antennas have to be up. We need to think about the possibility of this occurring, like in all other ANCA-associated vasculitis patients, so that we don't overlook it or detect it once the patient has a severe PE. Gastrointestinal involvement is affecting a third of the patients, generally in the form of eosinophilic gastroenteritis, much less commonly in the form of mesenteric vasculitis or colonic vasculitis. If it occurs, according to the French studies, which we'll talk about briefly later on, it portends a poor prognosis, and as a result, when they did the studies evaluating the 5-factor score, it was borne out that gastrointestinal involvement carried a poor prognosis, and that's why it was included in the 5-factor score. I already mentioned renal disease affecting a quarter of patients, generally less severely than patients with Wegener's or microscopic polyangiitis. Histopathologically, it's indistinguishable from ANCA-associated vasculitis, and the eosinophils in the lesions are rarely found and few and far in between. So it's not as prominent than in other organs. I'm not aware of a real eosinophilic glomerulonephritis ever being reported on any of the renal biopsies that we did. So let's address some of the questions. This is the clinical spectrum, but how do you actually make the diagnosis? Are there criteria to use? At this point, there are diagnostic schemes. They're sometimes referred to diagnostic criteria, even though in the strictest sense, they really aren't. The first to be put forth came from the Hammersmith Hospital Nephrology Group some 30 years back, the so-called Lanham's criteria, and that was based on 16 patients seen at the Hammersmith and the 138 patients reported in the literature by that time. And this is a set of criteria that is based mostly on clinical rather than the pathological criteria which were used previous to that, just based on the original report from Churg-Strauss. So they insisted that all 3 of these criteria needed to be fulfilled. So patient had to have asthma, peripheral eosinophilia, and then systemic vasculitis involving 2 or more extrapulmonary organs. So this is quite a tall order, and most patients that we diagnose with Churg-Strauss syndrome nowadays will probably not fulfill this quite yet. Word about the American College of Rheumatology criteria. They've been quite maligned for a variety of reasons, but surprisingly enough for Churg-Strauss syndrome, the American College of Rheumatology criteria actually work quite well. But let's remind us that the goal of these criteria was to provide classification criteria for therapeutic and epidemiologic and other studies. So they were originally designed rather as a research tool rather than to provide clinicians with a diagnostic set of criteria. They were based on prospective data from patients referred for with a specific diagnosis, and in order to qualify, they had to have evidence of vasculitis. There was no gold standard or standardized definition for making the initial diagnosis. And of the 807 patients that the ACR criteria were derived from, only 20 patients actually had Churg-Strauss syndrome. So keep that in mind when we're using these criteria. And so not everything is really written in stone about this. Nevertheless, in the clinical setting, it actually works quite well. So if there is some clinical evidence or a clinical surrogate of vasculitis, and patient has 4 of these 6 items listed there, the diagnosis of Churg-Strauss syndrome is actually quite solid. So again, there are asthma, peripheral eosinophilia, peripheral neuropathy attributable to systemic vasculitis, transient pulmonary infiltrates on chest radiography, paranasal sinus abnormalities, or a biopsy containing a blood vessel with extravascular eosinophils. Last kid on the block was essentially derivative that came out of the Chapel Hill Consensus Conference, which was convened in 1992. Actually, the report came out in 1994, was a committee of internists, rheumatologists, nephrologists, immunologists, and pathologists. And I have to say this tongue-in-cheek, no pulmonologist was involved in that. So the goal of the conference was to reach consensus on names and definitions for some of the more common forms of vasculitis. And even though this set of definitions has left quite a mark in the field, I don't think we've reached consensus on this yet, and I'm not sure we ever will. Nevertheless, what are the criteria? Well, asthma, eosinophilia, eosinophil-rich granulomatous inflammation involving the respiratory tract, necrotizing vasculitis affecting small to medium-sized vessels, and most importantly, you can use surrogates. So, if you have mononeuritis multiplex, that counts as the presence of vasculitis. If you have nodular lesions on chest CT, if you apply this, that counts as granulomatous inflammation of the respiratory tract, and so on. So the application of these has quite a bit of leeway. Now, taking all this into account, when we applied these different criteria in our cohort of 99 patients some 10 years back, it's not surprising to find that 8 patients didn't completely fit any of these schemes. Lanham's criteria were the least sensitive, and the ACR criteria were the most sensitive. So what does it mean at the end of the day? Well, you have to put it all together, and the diagnosis of Churg-Strauss syndrome should probably be based on as much evidence as possible, but you got to keep in mind that not every patient will have the full-blown picture, and then you'd still have to make treatment decisions with that in the back of your mind. What about the role of ANCA in this disease? Well, in our cohort, when we looked at the presence of ANCA at presentation of the disease, we found it in almost 3/4 of the patients at diagnosis before they had been hit with any glucocorticoids. However, very quickly, after several weeks of glucocorticoid therapy, the ANCA turns negative. So 36% of patients whom we saw shortly after the initial bout of disease for a consultation, ANCA were not present, leading to the lower frequency of 36%. Now, with a disease flare, again, 75% of patients were positive, and those patients in remission hardly ever had ANCA. So when we take that into consideration with what's reported in the literature from other centers, which are usually also all referral centers, I think the frequency of ANCA occurring at the presentation of disease is probably best estimated anywhere between 40 and 70%. My hunch is that at the very beginning of the disease, it is probably higher than some of the studies want us to believe, and for whatever reason, it seems to be very sensitive to steroid therapy in this disease. Now, most of these ANCA are actually MPO ANCA, and there seems to be a correlation of the levels with disease activity. This just shows 3 examples of patients where the ANCA levels actually with subsequent flares became lower and lower, but still were linked very nicely to disease flares. Does ANCA and its presence in Churg-Strauss syndrome affect the disease phenotype? Some authors have proposed this and have stated that the presence of ANCA portends a more vasculitic disease phenotype versus one that is more shaped by eosinophilic inflammation. Cynico, which is a large 100-patient study out of Italy, published some 5 years back now, stated that the presence of purpura, alveolar hemorrhage, glomerulonephritis, mononeuritis multiplex was significantly more common in ANCA-positive patients, which is consistent with these being the disease manifestations of microscopic polyangiitis, hence the overlap between Churg-Strauss vasculitis and microscopic polyangiitis. However, in the French study, as well as our cohort, we could not clearly confirm such a relationship. And for our patients, the only association we found was a very small association, possibly of ANCA and CNS involvement. But keep in mind, these are very low numbers of patients. And so ANCA-positive patients had a little bit higher frequency of CNS involvement. I do not want to overinterpret this. However, there was no difference between ANCA-positive and ANCA-negative patients when comparing the type of immunosuppression needed to control disease activity when looking at the frequency of vasculitic relapses, or when we looked at patients who actually had some association with leukotriene receptor antagonist treatment. Again, those patients that had seen that drug while they were evaluated for Churg-Strauss syndrome, again, the same split between ANCA-positive and ANCA-negative patients. Now, some people have said that in cardiac involvement is more common in patients who are ANCA-negative than in those who are ANCA-positive, and that trend seems to be the case, at least it was in our cohort. However, it did not reach statistical significance, and again, there's certainly no discriminatory value in this whatsoever. Which laboratory tests should we follow to follow disease activity? There is really no good published data that can guide us in any way, so I can only leave you with what we do. We measure the eosinophil count, and clearly when that is up, the patient is usually in trouble. We measure sedimentation rate and C-reactive protein as non-specific markers of inflammation. I also look at immunoglobulin E levels because frequently they're elevated in patients with active disease, and they go down with successful treatment and come back with relapses. And in MPO-ANCA positive patients, I also follow the MPO-ANCA levels. Additional tests, well, none of them can be recommended for clinical routine, even though a variety of markers have been reported in the literature as tracking disease activity. What about leukotriene inhibitors or other drugs? 10 years ago or 15 years ago by now, there was a lot of hoopla about leukotriene receptor antagonists probably causing Churg-Strauss syndrome. This goes back to the original publication by Wechsler in 1998, who reported 8 patients who developed Churg-Strauss syndrome following steroid taper in asthmatics on Zephyr-Lucast. When we looked at this issue in our series, it was not as clearly associated with the use of leukotriene receptor antagonists. The Churg-Strauss patients did not seem to flare when they had a pre-existing diagnosis and subsequently were given leukotriene receptor antagonists for the management of their asthma. The one piece of evidence from our cohort that convinces me the most that there's probably nothing to this is that the time interval between the onset of asthma and the onset of vasculitis was exactly the same in the patients who had received leukotriene receptor antagonists versus those who had never been exposed to these agents. A case control study from Germany and France, published a couple of years ago in 78 patients, looked for any role of asthma drugs that were given to asthmatics and an association with the development of Churg-Strauss syndrome, and they identified that multiple agents were associated with an increased risk. So it really comes down to the withdrawal of steroids that is given for asthma that is allowed by these additional medications, leading to unmasking of a probably pre-existing smoldering Churg-Strauss vasculitis. A few other things to consider in this context, just numbers that have been published in the context of this issue. The incidence of Churg-Strauss syndrome in the general population is 0.9 to 3 per million. The incidence of Churg-Strauss amongst severe Leukocyte users is 60 per million, and the incidence of Churg-Strauss amongst asthmatics is 18 to 62 per million. So there's quite a bit of overlap between the incidence amongst asthmatics and the incidence amongst the Leukocyte users. The NIH had some 10 years ago assembled a workshop looking into this issue, and they found that 88% of patients who had developed Churg-Strauss syndrome in the context of leukotriene receptor antagonist therapy had the development of the Churg-Strauss syndrome in association with a glucocorticoid taper. This slide just summarizes the arguments that are out there that are currently being held against this. We mentioned the widespread use of leukotriene receptor antagonists for asthma, which coincided with the observed 2 to 3-fold increase in the incidence of Churg-Strauss syndrome. The clinical phenotype, I mentioned that, doesn't differ between those patients who've received leukotriene receptor antagonists versus those who didn't. The time of asthma to vasculitis development is the same in both groups, and well, I think we mentioned all of this already, so we can skip it. How should patients be treated? The goals of therapy are, first of all, minimize tissue damage, and with that, we reduce and eliminate the eosinophilia. That's the first order of business. Secondary order of business is, in order to minimize the glucocorticoid exposure, we need to prevent relapses. Glucocorticoids are very effective at reducing and eliminating eosinophilia, and with it, the disease damage that comes from it in Churg-Strauss syndrome. However, patients cannot be maintained on high-dose glucocorticoids for long periods of time without the well-recognized ugly side effects. So in most of our practices, we take an approach to the treatment of Churg-Strauss syndrome which is similar to the treatment approach that we take for other ANCA-associated vasculitides. We try to separate the patients into those with severe disease and those with not severe disease. And severe disease is defined as either having the patient's life at risk or having an organ involvement that puts the affected organ at risk for irreversible damage. That's clearly the case with heart involvement. That's clearly the case with renal involvement. It's clearly the case with mononeuritis multiplex and CNS involvement. And it's certainly the case in the rare event of alveolar hemorrhage. And it's probably the case in the situation of a severe gastrointestinal involvement. So in any of those, we want to put the patient into remission quickly and effectively and definitively, and for that we generally use the combination of glucocorticoids and cyclophosphamide. And then once remission has been induced, we follow this up with remission maintenance therapy, which can consist either of azathioprine or methotrexate. When patients flare while being on remission maintenance therapy or during the taper, then we really have to scratch our heads and resort to some salvage therapy. Fortunately, that occurs very rarely, but it does occur. Now, in contrast, patients who have none of these significant organ involvements, we can get by with less aggressive therapy, and frequently we start them out on glucocorticoids alone and see how they do, try to taper them and maintain them with the lowest dose of prednisone possible. And if that dose is anywhere below 20, we're frequently satisfied. However, if we see flares occurring at prednisone doses higher than 20, then we're thinking about throwing in another remission maintenance or steroid-sparing agent. And in my practice, the first choice of that is really azathioprine, but others may use methotrexate, and hydroxyurea has also been proposed in earlier studies, mostly in patients who were ANCA negative and had predominant eosinophilic disease. We don't really have a whole lot of good data to back all of this up, so let's review what's out there in terms of data. The French have studied the largest number of Churg-Strauss syndrome patients in the context of randomized controlled trials. Sometimes the data are difficult to interpret because these patients were lumped in together with patients with PAN and microscopic polyangiitis. So sorting out the results with respect to Churg-Strauss in isolation is sometimes difficult. They used corticosteroids plus minus plasma exchange versus corticosteroids plus minus cyclophosphamide. Mean follow-up of 7.3 years. They found the relapse rate for Churg-Strauss to be 20%, not necessarily related to the disease severity or the treatment group that they were assigned to. And they found a marginal survival benefit with cyclophosphamide for patients with severe disease. We can comment briefly on the 5-factor score because subsequent studies on Churg-Strauss syndrome factored this factor in. Now, that's not good English, but you know what I mean. So the 5-factor score is an elevated serum creatinine of significance, proteinuria of 1 gram a day or more, severe gastrointestinal involvement, cardiomyopathy, or central nervous system involvement. And this 5-factor score, again, has been validated in a heterogeneous cohort of patients consisting of Churg-Strauss syndrome and PN and some microscopic polyangiitis patients. Why is this significant? Well, the 5-year mortality is substantially different depending on how many of these factors you have. If you have none of them, the 5-year mortality was 12%, 26% if you had one factor, and 46% if you had 2 or more of these factors. The French study group subsequently looked at Churg-Strauss syndrome in patients without any of these poor prognostic factors. They studied 72 patients, which were all initially treated with glucocorticoids. Then the patients were randomized to receive either azathioprine or cyclophosphamide if they did not achieve remission, if they had a severe vasculitic relapse, or if the prednisone dose could not be tapered below 20 milligrams. And in the interim analysis at 10 years, they found that only 19 patients had been randomized, and then the trial was halted. Nevertheless, they reported the results. So they state that steroids initially induced remission in 93% of patients, and at the end of follow-up, which was a mean of 5 years, 79% of patients were still in remission, and 35% of patients had required treatment other than corticosteroids or retreatment. It's interesting that this doesn't add up to 100%, but most relapses occurred in the first year, and most relapses occurred during the steroid taper. So this actually does reflect what we see in clinical practice and why we're often struggling with the management of these patients. Of the patients who were in remission, 83% were still on steroids, 5 for adrenal insufficiency, but 50 for their asthma and sinusitis. And again, this reflects what we see in the clinical practice. It's relatively easy to get the vasculitis under control and prevent it from recurring, but we're still left with the hard-to-treat asthma and sinus disease. Now, they also did another study that actually looked at Churg-Strauss syndrome with poor prognostic factors, and 48 patients were enrolled in that trial. 19 had renal involvement, and patients were randomized to either get 6 or 12 pulses of cyclophosphamide. Again, 91.7% of patients were alive and in complete remission at 5 years. 73% experienced a flare during the trial. Most of these flares were minor, And the minor flares were statistically more common in the patients who had received the shorter course of cyclophosphamide treatment. But again, 89% of patients remained on some maintenance glucocorticoids. So it seems that patients with Churg-Strauss syndrome cannot get off glucocorticoids altogether, and the biggest unmet need is steroid reduction in the management of Churg-Strauss syndrome. What about refractory disease? Very briefly, several drugs have been thrown out, and there are some small case reports or small cohort studies on interferon alpha, rituximab, omalizumab, and anti-IL-5 agents, and I'll run through them very briefly here. Anti-TNF first proposed in 1998, a case report of 4 patients in the Annals of Internal Medicine from Germany. All patients had refractory disease, and there was a proposed rationale consisting of interferon alpha being used in idiopathic hypereosinophilic syndrome, where it worked quite well. It acts on the T cells to influence cytokine production, but it also has a possible direct effect on eosinophils. It seemed to work in these patients. However, they already pointed out in that report that the disease is prone to relapse the minute interferon alpha is discontinued. And they had quite a bit of complications in these patients subsequently. Most recently, just appearing online this month, was a follow-up study of 13 patients from that same center. And when you read that, you walk away with very little enthusiasm for interferon alpha as a valid treatment modality. So I don't think currently that there's a significant role of this agent in the management. This is in contrast of rituximab, for which there is quite a bit of enthusiasm about this right now. This was first triggered by a report of 2 cases from David Jane's group out of Cambridge, showing up in ARD, where patients seem to respond very nicely to rituximab. Since then, there's a total of 10 reported cases as of yesterday in the literature. One study is of particular interest. Again, this comes from David Jane's group in Rheumatology 2008, where a reduction in serum IL-5 levels was observed preceding a reduction in circulating eosinophils after rituximab application. We at Mayo have submitted an abstract to the ASN on our initial pilot trial of Churg-Strauss with active renal involvement. We were aiming for 5 patients, but patients with renal involvement were hard to come by, so we stopped it after 3 patients. All of these were ANCA positive. All patients responded well and are currently in remission. However, in one patient, the asthma flared, and the asthma still represents a treatment challenge. We do have a rituximab for Churg-Strauss syndrome trial on the drawing board in the VCRC, and we're still in negotiations about obtaining funding for that. What about omalizumab for Churg-Strauss syndrome? It's a drug that's used for asthma management. It's a murine anti-human IgE monoclonal antibody that inhibits the binding of IgE to its receptor, and it binds free IgE in the serum. It reduces early and late phase responses to allergens and has some effect on the eosinophilic infiltration. It's generally well tolerated, and it's contraindicated in patients with helminthic infections. Initially, there was a case report in 2008 of 2 patients with Churg-Strauss syndrome who apparently did well on this agent, but since then, Mike Wexler has reported several patients who developed Churg-Strauss syndrome while being treated with omalizumab for their asthma, and the same theme occurs here like we're seeing with leukotriene receptor antagonists, that namely once you start tapering the prednisone for the asthma, with the help of this agent, you may unmask the vasculitis symptoms of Churg-Strauss syndrome. So as a result, maybe omalizumab is not such a great agent to consider any further in the management of Churg-Strauss syndrome. Now, more excitement certainly about anti-IL-5 antibodies, and the one agent that has had one publication so far, and most recently, is mepolizumab. IL-5 is a Th2 cytokine that's essential for eosinophil maturation, plays a role in chemotaxis and adhesion to vascular endothelium. Anti-IL-5 has had some promising results in idiopathic hypereosinophilic syndrome. However, there seems to be a paradoxical rebound after discontinuation of the agent. In Churg-Strauss syndrome, elevated serum levels of IL-5 have been documented and seem to track the disease activity. The potential role of this agent in asthma is less clear, and a pilot trial of this agent in Churg-Strauss syndrome has been conducted by Mike Wexler and his group and has been published in CHEST, in Journal of Allergy Clinical Immunology just recently. It was an open-label trial of 7 patients. All were had steroid-dependent Churg-Strauss syndrome. They received 4 monthly mepolizumab infusions, and the goal of the trial was to determine whether steroids could be reduced. All patients tolerated the drug well, and there were no safety issues observed in this small study, and all patients were able to successfully reduce their steroid dose below the levels that they required previously. However, the Churg-Strauss syndrome symptoms recurred after discontinuation of mepolizumab, and the patients subsequently required an increase of the glucocorticoid dose again. So maybe a steroid saving effect that deserves further exploration, but obviously or apparently not a complete turnaround of the pathogenesis of the disease that leads to relapses. So how have we done in terms of survival over the years? It certainly improved substantially. As I mentioned earlier in my talk, the initial description was a post-mortem study. In the 50s to 70s, the reported mortality was in the order of 40%. Between the mid-60s to the mid-90s, it ranged in the order of 25%. And when we looked at the mortality in our patient cohort that was seen in the 1990s at Mayo and compared it to US life tables, there was no increased mortality compared to the general population. But that doesn't mean that the patients are feeling well while they're alive. So there is a clear-cut unmet need in this disease. So let me summarize by stating that Churg-Strauss syndrome is an uncommon form of systemic small vessel vasculitis characterized by the presence of asthma, eosinophilia, pulmonary and systemic vasculitis, and granulomas. And in the absence of diagnostic criteria, it remains largely a clinical diagnosis. The disease is associated with P-ANCA and MPO-ANCA. However, a large proportion of patients does not have ANCA, and to what degree the presence of ANCA really shapes their disease phenotype remains an open question at this point. There is probably no causative role of leukotriene receptor antagonists or any other drugs that allow the lowering of glucocorticoids for asthma management. The treatment approach in principle is following the guidelines for Wegener's and microscopic polyangiitis, and the treatment of refractory asthma remains the biggest challenge for most patients and their physicians. And with that, I'd like to close.
Question that specifically follows Ulrich's talk, and I'll ask specifically to Peter and to some extent to Ulrich to address. What about IV Cytoxan? And is that replacing oral Cytoxan?
So that's an excellent question. I actually, although it might be hard for you to imagine, I actually had to take slides out of my talk. And one of the set was about IV versus oral, and I could go on with that. There are now good data. So the question is intravenous cyclophosphamide pulse therapy equivalent to daily oral, which has been in use for the last 30-something years? And I think the bottom line answer is yes, with the two caveats. One is, an important trial was done last year, published last May in the Annals of Internal Medicine by Kristen DeGroot and Company, which is looking at IV versus oral for induction of remission, showed equivalence in terms of the rate of putting people into remission. Two things to note, which is that, one, the the dosing used is different from what you think. It's not the quote NIH lupus dose of 750 milligrams per meter squared. It's a different regimen. It's 15 milligrams per kilogram every 2 weeks for 3 doses, and then every 3 weeks. And the rationale behind that is it's a little kinder and gentler, but more frequent, and it may allow for continued immunosuppression. And I think if you're going to use the IV, you should do it according to that protocol. There are some older data that suggest there's a possibility of increased relapse rate using IV. They didn't see that in the study. I think that at this point it's a very good option. You're only talking about using the drug anyway for 3 to 4 to 5 months in many patients, but I think especially for recurrent, if you're going to use cyclophosphamide.
All right, the next question is for Connie, and I'm going to add a little bit of my piece onto it too. The questioner says the role of dendritic cells in vascular response suggests an immune response to a number of different bacterial antigens. Is this a generalized response, or are there specific exposures or a specific bacteria that's suggested by some of your fancy proteomic studies or some other studies that can give us some clue as to exactly what is the environmental trigger that deals with this very active vascular endothelium? Oh, and vascular tissue as well.
So it seems that the blood vessels have a preference for TLR2, 4, 5, and maybe 3, that they are not so interested in 7 and 9. And if one puts a crude rule to that, they are more interested in bacteria than they are interested in viruses, because the viruses are falling in the TLR7, 8, and 9 category. So in that sense, yes, there seems to be a dissection that the immune system utilizes blood vessels more for the monitoring of bacterial infections than viral infections. Amongst the bacterial infections, I don't think it will be easy to bring them down and say it is going to be this or that and that particular pathogen. Many attempts have been made to go into the tissue and find the pathogen, and these attempts have not led anywhere. However, if you consider that we're changing our understanding of this process, that you don't need to have the bug where the action lies. All you need is a piece of the bug where the action lies, and that changes the entire phenomenon. So you could say somebody will have large vessel vasculitis if they have a particular bug within their gut.
Now,
That changes it, right? You're not going to look for that bug in the aorta.
Now, along the same lines, and this comes from me, this is in the centuries ago when I learned rheumatology, there was a lot of discussion about the relationship between Takeuchi's arteritis and maybe giant cell arteritis and tuberculosis. And in fact, we poo-pooed that, that's crazy. This was just, coincidence. But in fact, there were a number of these observations made, especially in Mexico with the people at the Cardiology Institute. So circling back to your discussion about environmental triggers and Takeuchi's arteritis and giant cell arteritis, what about the role of tuberculosis?
That's a good point. Actually, our colleagues in India continue to be very concerned about that association. And I visited Sao Paulo last year, and Sao Paulo has a cluster of Takayasu patients, and so do they see association of a TB with Takayasu's disease. Interesting enough, they have tried to show that there is genetic material of mycobacteria in the aorta. They could not show that. They've also done plasma studies, but the association remains. And I think what it may mean is that there are immune responses that are shared between these. If you're not as capable of defending yourself against mycobacteria, does that put you at risk to have aortitis in a Takayasu setting? So I think that we need to keep that as a serious option. As I said, in India, our colleagues do see that amongst their Takayasu patients, whether they are early in the disease or chronically in the disease, they have to be alerted to the possibility of a tuberculosis. And so do our colleagues in South America.
Carol, what do you think about the association with tuberculosis?
Yeah, I don't know if I'd have a lot more to add beyond what Connie said, and I think it is something that continues to be of interest as we move forward and trying to look and see how microbial pathogens may play a role.
Now, there's another series of questions that are all hover around the same topic here, and I think the large vessel disease doctors, I think, should try and address this, and that is, do you stage your patients? That is, do patients, then you see them, and you make a clinical diagnosis, do you visualize the entire aorta, the entire vascular system in these patients? And if you do, what do you do about it?
So Carol gave her answer before when you asked, like Connie says. The answer is yes. I think that depends on the setting. So I think the answer is, for tracheostomies, it's self-evident. This is the disease. I certainly get a full MR angiogram I prefer MR because you're going to want to be repeating them every 6 months, for example. That's our protocol in general. And you don't want to do CT angiography. Not that CT doesn't give you beautiful images. It gives you beautiful images, except the radiation and the eye-dated contrast you have to keep giving is a problem. We do it from basically the bifurcation of the common carotid down as far as you can. You want to capture the renals as well. If you need to get further down, because there's an interest you may need 2 images. It depends on your scanner what you can do. If you're worried about head and neck, you always need a dedicated one because the vessels are different and the approach is different. It's MRA, not MRI. The MRI image, you want both, but you really care about is the MR angiogram. The MRI looks at wall thickness and such, for which we do not exactly know what to make of all that, but the lumen is very important. In giant cell, I think everybody should have a baseline evaluation for at least aortic root disease, if not general in the thorax, because of the markedly increased incidence of aneurysms. We know that 15 to 25% of patients with giant cell arteritis develop aortic disease, and if they have peripheral arterial disease beyond the aorta, I would stage them and I would follow them regularly. As frequently as diagnosis, it's hard to know. I think we'll learn over time. One thing to remember, not all arterial lesions certainly not all aneurysms lead to problems down the line. You follow?
All right, let's get down to the nitty-gritty here. Patient presents to you with PMR. Do you do a vascular workup or do you do a temporal artery biopsy? And if you do, what information is it giving you?
Well, you certainly do a full history and physical related to cranial symptoms and giant cell arteritis, and those patients at every visit should get a full vascular exam. It doesn't take long to do 4-limb vascular exam, listen for bruits, pulses, ask about claudication. But I think if they only have PMR symptomatology, treat them for PMR.
I think where the vascular status evaluation is particularly helpful is in the patient with a negative temporal artery biopsy. That's a very challenging patient, the biopsy negative patient. They come from different directions. They come out of the eye clinic where the ophthalmologists see them and say, this smells and looks and feels and behaves like GCA, that we have done a biopsy on one side, we have done a biopsy on the second side, that patient remains negative. So in that patient, I think it is very helpful to go forward and see whether you find lesions in the large blood vessels, because that would help you to make a diagnosis. So back in the late 90s, we did a study still at Mayo looking at the subclavian GCA patients, and at Mayo you had a procedure of course I get a biopsy, and 50% of these patients had a negative biopsy that they had documented angiographic changes in their subclavians. So I think there you can really have help coming from that direction. The second question is, do you follow your patients that have a positive biopsy for aortic disease? One of the hurdles we have run against is actually that it is not so easy to have norm values for what a normal aorta looks like in a 75-year-old. A normal aorta in a 75-year-old does look different from a normal aorta in a 35-year-old. So one has to be careful with these percentages that so and so many percent of these patients are dilating the aorta. That may be partially a reflection of the fact that they are 40 years older than the controls. But indeed, the vascular imaging is particularly important in helping us stage these patients. The move is to go beyond magnetic resonance. Yes, of course, as Peter pointed out, the CT angio gives you nice pictures, but the radiation load is remarkable of these examinations. We do not know entirely whether indeed the MR examinations are totally inert. The contrast media may not be as inert as we think, and you're aware of these discussions. So the next move has to come to bring imaging technologies to us that allow us to not only reduce any risk and side effects of repeated examinations for the patient over the long term, particularly in patients with Takayasu's disease who may have these examinations over 20, 30, 40 years, and to, at the same time, be capable of quantifying metabolic events that occur in the vascular tissues. So yes, that is enormously helpful to have it. It has to be done with care, and it's important to know what to look for. Of course, also in the GCA patients, you're dealing with a population that has a naturally higher occurrence of atherosclerotic disease. You know, and there's some gray zone, what's atherosclerosis, what's vasculitis, where are the two coming together, where they are distinct. There is probably a population of patients emerging that have rapidly evolving atherosclerotic lesions that may, for all purposes, have some similarities with frank vasculitic lesions, and the question is, where does one disease stop and the other disease start? So you've got to be aware of that when you image an 84-year-old individual.
Why don't patients get involvement of their coronary arteries or intracerebral arteries in these diseases?
The intracerebral arteries, they actually do not, because the blood vessel in the brain has a different makeup. The intracranial artery does not have this layer of this layering of the vessel wall as the blood vessels have it outside. For the coronaries, I think what's happening is that in most cases they get it through the aortic wall. That's particularly so for the Takayasu patients. The wall becomes thick, and simply there's mechanical restriction of blood flow to the coronary. So that one needs to keep that in mind.
For Ulrich and Peter,
Just say it's not only the osteo lesions are by far the most common, but it's not excluded that you can have more distal coronary lesions of Takayasu's that occurs, and actually that is it's not a disease we think of as killing patients, but the patients who die from the Takayasu's, actually coronary disease is up there on the list. And so low threshold for thinking about it in otherwise young women you wouldn't think about coronary disease.
Yeah, very important. You know, when you see patients that had a bypass at the age of 29, ask the question why. So that's not unusual to bring these women into the vasculitis clinic, and then you find, oh, by the way, they had a bypass 10 years ago. So I think that's important to keep that in mind.
now Ulrich and Peter, what do you consider an adequate infectious disease workup in patients that present to you with possible Wegener's or Churg Strauss?
Well, you do it until you have clarity and know what you're dealing with, and that varies from patient to patient quite extensively. So I don't think I can really give a very good answer to that question. It depends on whether the patient is already on immunosuppressive drugs or not, and
Well, what if they are on immunosuppressive drugs?
well, it depends on where the infection is. If there is a new lung infiltrate, for instance, which is what we deal mostly with, then the question is it reactivation of the disease or is it an intercurrent infection? The first thing we do is bronchoscopy with BEL and immune-compromised host protocols to rule out that the infiltrates are blood, alveolar hemorrhage, and to get the samples to look for opportunistic infections. Keep in mind that up to 50% of patients with ground glass infiltrates may not have hemoptysis, even though the ground-glass infiltrates are directly related and caused by alveolar hemorrhage. So just because a patient isn't coughing up blood, don't think it's not alveolar.
Are there any other ways of deciding whether the pulmonary infiltrates are active or not active? Are there non-invasive techniques to be able to tell this? Imaging techniques?
Well, you follow them over time with imaging, so you see how the lesions resolve over time with your treatment, and you take it from there.
Okay.
I think there's the other, I agree with everything he said, and I would add that one of the ways to try to differentiate is to do what we do, which is to do a full history physical and really look. You're looking for other signs or symptoms of active disease elsewhere that may help you. On the other hand, you could have coexisting infection and active disease. I think it actually is more difficult in the patient who's on treatment and who's already with the diagnosis established. That's where you get into complications. They can have infection and active disease, etc. And that's where it would be perhaps even more invasive than the new presentation for which you've done good workup looking for infection, but you have evidence of new onset disease. So I would think of a low threshold for worrying about infection in our patients with chronic immunosuppression. And I think you just have to be aggressive and have some common sense and be humble enough to know that the decision you make may still be wrong even though you've done a good evaluation. And you may have to at some point say, I think they're not infected, I'm going to treat them immunosuppressive, but follow them closely if it goes wrong. Similarly, the other way around, you're treating for infection, you better still have a strong lookout for whether the vasculitis is coming back. And I've got news for you, if you see enough of these patients, and we all do, you're going to have patients who are clearly infected and clearly have active vasculitis, and that's a long night for a while.
Carol, what about, and apropos of what Connie was saying, what about the use of hydroxychloroquine, for example, or anti-IL-6 therapies in patients with refractory disease, or even early disease, for the matter of fact, with Plaquenil?
Yeah, I don't think that there's really been any support as far as for the use of hydroxychloroquine and Tachyossus. It would be nice. It's certainly less toxic agent than all of the other ones that we've talked about, but there really hasn't been any support as far as for using that. And I think all of us have been interested in what IL-6 may offer. There has been some small studies, which I hadn't mentioned as far as these have largely been in abstract form in Tachyossus, that I think will ultimately lead to further standardized investigation. Certainly pathophysiologically, that offers some interest as far as where that would look at, but right now, again, there's still just very limited information, not something that would be used clinically right now.
Is there any role for anti-TNF therapy in large vessel disease?
Well, I think so, and again, we have seen encouraging information with particularly Rituximab, to a lesser degree etanercept as far as in non-standardized, non-randomized trials. Unfortunately, there have not been randomized trials in Tachyossus arteritis to date. We have tried quite vigorously as far as trying to get such studies approved, but there are a number of challenges given the experience with anti-TNFs in other forms of vasculitis. But we still think that we have seen a very encouraging signal as far as using these in Tachyossus, and it has been part of what I've done in clinical practice.
We use them, I was actually one of the authors with Gary in the first set of reports, but I will tell you, my experience has not been that there's a difference among the different TNF inhibitors. I think there may be a bias how we're selecting. We certainly had failures. We've certainly had people who had serious disease through these drugs, and we've certainly had serious infections, including someone who died of tuberculosis. But we've had, I think that Carol would agree, it's an agent that we use. The negative studies of TNF inhibition for giant cell arteritis and polymyalgia are something to think about, and to what extent you think there's a spectrum of disease. Tachyossus, I think it's concerning, and it makes our enthusiasm lower. It certainly made the NIH's enthusiasm lower, and or was it the FDA? I forgot what we applied to. I think that it's an option, but as you can see from the study that we're running, we did not feel that any of the agents out there have strong enough evidence that not putting people with Tachyossus or even GCA on an immunosuppressive agent beyond glucocorticoids is wrong, and therefore it's appropriate to have placebo
All right, everybody, our time is up. What a fantastic program. Let's thank everybody.